Hello. Hello, good afternoon, everybody. My name is Professor Tariq Abdulgawad. I'm from Cairo University. I'm a board member of the ICU DDR. I have the privilege to replace one of my colleagues from Nigeria who couldn't make it, unfortunately, and this is a privilege for me to introduce the first presenter, Dr. Rehana Kader, PhD, is a clinical psychologist of Life Vincent Pallotti Hospital, Cape Town, South Africa, Honor Senior Lecturer, Department of Psychiatry and Mental Health, University of Cape Town, Associate Staff of Alcohol, Tobacco and Other Drug Research Unit, South African Medical Research Council, board member of the International Consortium of the University for Drug Demand Reduction, the ICU DDR. Dr. Rehana will speak to us about Africa and preparatory work for curriculum development. Dr. Rehana. You need this also? Okay.
Okay, good afternoon everyone, and thank you for attending our session. It's such a far venue from the main hall, so appreciate you walking and coming in the sun. So, let me tell you a story about how we started. I think in 2015, there was the first ICU DDR meeting, and that's where the idea was conceived of developing or establishing an international consortium for drug demand reduction. Subsequently, in 2018, we had the Africa Continent chapter opened, and South Africa's chapter was in 2019. So when we established our chapter in 2019 in South Africa, the committee then had the question of, we know that we have to implement some kind of curriculum at a university, but how do we start? Where do we start? Okay, what's the roadmap? And collectively we decided that maybe we need to start to find out what the universities have, what are their needs, and how we can help them in terms of developing an addiction science program. So basically that's the overview of the presentation, but I think what surprised us most was the outcomes. We didn't expect, and I'll speak about the outcomes, but it was a pleasant surprise to us how much came out of the needs assessment. I think like in all low and middle income countries, South Africa also has a high prevalence of substance use, but the treatment gap is quite wide between people accessing services. And then the question was, why are people not accessing treatment services? And several research was done in South Africa, and the results was that we do not have enough expertise in addiction professionals or in the workforce, and hence the gap just widened and widened and widened. Then to address this gap, in 2011 and 2012, two universities in South Africa, University of Cape Town and University of Stellenbosch, established a postgraduate diploma in addictions for a multidisciplinary profession. And this is the only two programs or certified programs in the country so far. Okay. And then ICDDR's mission was, how do we expand this training so that we have a very efficient and competent workforce that can give the best service to people that's in need. So with that vision in mind, we decided to look at all the universities in South Africa, look at what they are offering and what do they need. And a needs assessment is very important because then that will inform what we're going to implement. Because often we go with our own assumptions that we just want to implement a UTC or a UPC, but that might not be the need of the university. Okay. So our specific objectives was to see what's available, but more importantly, what are the perceptions of academic staff in introducing a new curriculum? I think those of you that work at universities know the bureaucracy, know the resistance when a new program is offered. People are hesitant, they are a bit cautious. So we wanted to know, do we have their support? Are they ready? Are they willing to implement? And also having a certification for across the disciplines. We work in a multidisciplinary team, so we need to train people in a multidisciplinary way. And finally, is it feasible? Should we be having this program implemented? So the feasibility was very important for us. So if you look on my left-hand side, that's the map of South Africa. And we have 9 provinces in the country. And we have 26 public universities in our country. Okay? Of the 26, 21 offers behavioral health sciences. The other 5 universities are technical universities. Now if you see, the yellow circles is indicative of how many universities completed the survey. And we had a whopping 19 universities completed. So only 2 universities in the entire country didn't complete it. And this was an achievement, especially since it's a survey, it's really hard to get people to complete it. We also have a lot of private institutes, and we had 4 higher learning institutes. Yeah. We had a structured survey which we emailed to the academic staff, and this was guided by an implementation guideline that was produced by ICUDDR. So, although it was 19 universities, it was across departments, so 35 surveys were completed. And what we found out that the psychology department predominantly offered some form of addiction training compared to the other departments. And I think it's a no-brainer because psychology, our programs are very intense, it's very rigorous, so psychologists are trained across the board. The next question we asked was, what is the department's or university's capacity to implement an addiction science? And we found that 54% said that they have the capacity because they have adequate training. And again, it was the psychology department that came up with the high percentage of capacity. 42% said they only have a few staff members, they have too much workload, and it's going to be a challenge to implement it. And 8% said, no, we don't have the capacity, we don't have the staff, we don't have budgets, there's no training that's been provided for staff, so they don't have the capacity. So some of the gaps and challenges from the results that we got from these universities was there's not enough staff with up-to-date knowledge because they haven't been trained in substance use disorders. And there's not many training opportunities in the country to upskill them. SUDs are not a core focus at all in the teaching. And even though we have these 2 diploma programs, they don't lead to accreditation. So when a student finishes the diploma, they can't go and practice as addictional professionals. So this is quite an important challenge. And the curriculum right now just focuses on prevention, treatment, and aftercare, but important topics like harm reduction, medication-assisted therapy, assisting vulnerable populations are not part of the curriculum. So the next question we asked them, what would you be most keen on developing, which programs? And most universities said short courses, and the minimal universities said standalone degrees. And I think that's understandable because short courses are much easier to develop than standalone degrees. What was interesting was the continuous professional development. This was the second highest priority. And I think we assumed implementation of the UTC would be the first priority. But again, if we take a few steps back, if we don't train our academic staff and professionalize and equip them, they won't be able to do and implement the curriculum. Okay. Majority are ready and willing to start with the implementation process. They said they will benefit from both the UTC and the UPC. So this is important because we have a partnership and a collaboration with ICUDDR, and we asked them, what would you like from ICUDDR? And the kind of collaboration and support they want from ICUDDR. And again, this was a surprise for us that over 90% of the universities responded by they want to encourage research between students and staff. Again, we thought it would be implementation or training, but research came up as a top priority, and then the second priority was enhancing staff capacity. So you can see there's a theme coming out here that staff needs to be trained and developed first before implementation of the curriculum can take place. Again, it's the same theme. We need to upskill the professionals first and then the postgraduate students. So what are some of the areas that they want us to focus on is theory on SUDs, administer and the skills to administer screening and assessment, evidence-based counseling for individuals, families, groups, and communities. And like I said, what else is missing? But I think the last one is very important. What are the social determinants of substance use? Because often when a client walks in, we just see the individual and we see the substance use disorder. But you have to understand the context and what are the driving factors that leads or contributes to SUDs. And that was a strong point that we need to add in our curriculum. So here I come to the most exciting part, the outcomes. So we had a walkthrough training for 7 universities across South Africa. And here's a picture. It happened in the midst of COVID, and you can see that we all have our masks on. Although we were so cautious, myself and 2 of the other facilitators contracted COVID after the training. But in some ways, I'm cautious but to say it was worthwhile because our objectives were achieved. Because these universities that went through the walkthrough then started implementing parts of the curriculum. Okay. And then we started providing them with technical support, with guidance. We had meetings with them, particularly in bite pieces, what they can do, 1 module, 2 modules, etc. We published a paper in the Journal of Substance Use on the needs assessment. And we're in the process of now evaluating the challenges these universities had and the successes they've had in the process of implementation. And what is the most exciting thing, which we didn't expect to happen, that this needs assessment is going to be rolled out to the rest of the African continent. And I am so pleased to say that Egypt has completed the survey and they're going to speak about their results. Nigeria has completed the survey and they're going to speak about it. And then we're going to look at the comparisons and the differences. Tanzania is busy conceptualizing it. I am twisting Botswana's representative to start. So I think at the next conference, our vision is that we will have a few more universities. And then to aim for the stars, we hope that we can do this globally for everybody else. So curriculum development is a long process. It's a journey. It has many destinations. We've done the needs assessment. We've looked at goals and objectives. We looked at strategies in terms of how we're going to implement it. We're busy in the implementation process. And now we're at the last step of evaluation and feedback. But remember, this journey starts all over again, and we come back again to it because this is a continuous process. Okay? So in conclusion, yes, we need curriculums in the university. We need to provide professionals with high quality care for clients and to develop the core competencies in them. And finally, I would like to acknowledge the team that was responsible for the study. And we're fortunate enough to have 3 members of the team, so I would like them to stand up. Professor Nadine Harker, Fergus Ashburner, Narain. And without them, we wouldn't have been able to make a success of this. So thank you very much.
Thank you very much, Dr. Rehana, for a very clear, well-directed presentation in our pursuit for the ICDDR to do the needs assessment survey of universities in Africa. The floor is open for a few questions. We have 5 minutes. She cleverly kept the time. Can I stimulate the questions? The surveys went to universities in South Africa. What type of colleges within the universities that responded? Are they are all PhDs, MDs? What type of responses you received?
So I think it was across the board. So we had the medical faculty, the psychiatry faculty, the nursing faculty, the social work faculty. Am I missing any? Psychology. So it was across the board in different departments. Social development.
So it is well represented, yes. The responses. Yeah, sure. Sorry.
Thank you. I'm getting converted. I wanted to know, in terms of the respondents, the 35, is it the number of universities or the number of individuals in the universities?
So we had 19 universities, and the 35 is the respondents across the university. So say, for example, one university, maybe 4 faculties or departments responded. Because we wanted a nice representation and not be biased and just take one department, yeah.
The analysis is mostly descriptive, so I'll just stop there. So then, and then, like, in terms of looking at the 35 that responded, what is that description? Is it mostly psychologists, or it cut across all the disciplines?
It cut across all the disciplines, but the majority, and my team can say also that the majority was the psychology departments. Prof. Nadine, am I correct? Prof. Nadine helped with analysis of the data.
Can you just tell us your name and your affiliation, please?
Henry from Nicaragua. My question is if there was some sort of understanding of priorities in terms of students or careers and also content. Is that something that there were some inputs in the assessment? I mean, and that question is because, of course, we always want everything for all, but oftentimes resources may not be available, and we may go little by little, and we'll set up priorities, and that's what I was wondering.
Some of the responses were very generic, so theory, core competencies in screening and assessment and across the board. But what were some of the new things that came out was the harm reduction that needs to be added, the medication-assisted therapy, the vulnerable populations, and especially in South Africa with HIV, the high prevalence of HIV and TB. So yes, there's a lot, but we have to look at context specific and how the curriculum can be adapted to what are the public health conditions and high prevalence of diseases in our country and how that impacts on substance use. So interrelated, if I'm answering your question correctly. So yes, it's starting off very broad, and the universities that are starting to implement, we're starting to narrow it down to what are their specific needs, because we can't do everything.
Amalia, Czech Republic, Prague, Charles University. Thank you, Rehana. I just wanted to make sure those programs you had on Stellenbosch and South African University are now not working. Both of them are now closed, and you are trying to find out the ways how to implement the curricula differently. And that was the needs assessment you presented, right? Am I right?
So, no, they're not closed. They're still running. And Fergus, maybe do you want to say what's been happening? Fergus is the convener of the postgraduate diploma in addictions at UCT. That's why I brought my team.
Hi. So the postgraduate diploma at the University of Cape Town and Stellenbosch still operates. We were funded very generously by the Western Cape Department of Social Development, but unfortunately now the programs are self-funded, so students have to be able to come up with the funds. But we've, with the team, we're continuously refining the curriculum to integrate UTC, UPC, and now I'm attending the URC, so hopefully that can even form part of it.
Any more questions? Yes, please.
Thank you. I'm Humphrey Bowman. I'm CEO of Touch Life, Glasgow, Scotland. My question is, as I last week I was in Edinburgh in psychiatric protest as regards human rights valuation when it comes to mental health electroshock treatment for psychiatric patients. So what is South African government or ICUDD doing in respect of any correlation between electroshock treatment and substance use a mental health issue? I don't know if you've visited that area at all. Thank you.
So, if I understand your question correctly, you're asking how are we addressing substance use and mental health in the training of psychiatrists? Yeah. So, Fergus UCT has a master's in addiction for psychiatrists, and we have other programs in PhD as well in upskilling psychiatrists in SUDs, but also in mental health. Psychiatrists are mental health professionals, but we've got a specialized master's degree. Yeah.
So you, if I understand your question correctly, you're specifically speaking about the training of psychiatrists. Okay, yeah. So at the University of Cape Town as well as the University of Stellenbosch, there's an MPhil for subspecialization for psychiatrists in addictions. And probably within that program, there might be a training in ECT. I know within the training of psychiatrists in South Africa, they get ECT training specifically, not necessarily on the PG DIP just yet. Yeah.
Okay, any more questions? Thank you all, and thank you, Dr. Rehana. Thank you very much for the effort and for the presentation. And moving to our next honorable speaker, Professor Michael Zonwa is an immediate past president of Nigerian Psychological Association and the representative of the ICDUR in Nigeria. Professor Mike. He is speaking about, again, the needs assessment for implementation of addiction science courses in Nigeria, tertiary education institution, perspectives or prospects and challenges.
Thank you.
Yeah, thank you very much. I like to, the lead paper presenter in this is Samuel Dakwak, but unfortunately, he was not able to be here. The Greece embassy in Nigeria did not give him visa, for which he's not here. So, but having participated in the study, so I now have to present the paper. But before I do that, I would like to make the point that this presentation is a highly preliminary presentation, very preliminary, and I need to underline that. Very, because it is still ongoing. For example, we have, as many of you may know, Nigeria is perhaps is the biggest country in Africa, with a population of probably 230 million, about that currently, and with 272 universities. 272 universities, out of which 149 are private universities and 123 are public universities owned by state governments and federal government. But this data was collected from 8 universities. So you can imagine what I mean when I said that the data is highly underlined, highly ongoing. So we can't make any decision based on what is on the ground. But it was important to see the trend, as it were, with this opportunity that the conference has presented. And it's also important to know that the study had no funding, and therefore it wasn't possible to stretch at a very high speed. Now to the main study. Background: substance abuse and addiction pose significant challenges to public health, necessitating a comprehensive understanding and effective response with multidisciplinary approach. Multidisciplinary, as we know, because no one profession can do that. The prevalence of drug use in Nigeria is fairly high, and as at 2018 is 14.4%. 14.4%, with participants drawn from a population of people aged 15 to 29 or so. I mean 69 years. 15 to 64 years, sorry. 15 to 64 years. So that's a productive population. And so, but if we, this data was collected in 2017 by UNODC with support from European Union and published in 2018. But the global prevalence rate in 2016 was 5.6. 5.6. And in 2017, data collected in 2017, published 2018, Nigeria was 14.4%. Although there are countries, for example, United States has, I think, 17.4% of prevalence, and these are those already with issues, those with disorders, 2022 data. So, but for us, we consider it high. So there is need for efforts to, bring the prevalence level down. And in that report, the commonest drug of abuse was cannabis sativa, and about 10.6 million users were found, followed by pharmaceutical opioids, essentially tramadol and codeine containing syrup, 4.6, and we also discovered in the research that there is one to 5, 1 to 5 female-male ratio. Okay? So, traditionally, addiction science was limited to the field of medicine, psychology, and social science. But now we know there's great expansion. And those days, it was taught in some medical schools, okay, especially at the postgraduate level. But the situation has drastically changed. And so, what were the reasons for this ongoing study? Please underline ongoing study. First is to look at the existing infrastructure in the educational facilities, the faculty expertise, and then available resources, and to identify gaps in the regulatory framework at the graduate and undergraduate levels, and to identify diverse perspectives on the current state of addiction-related education, treatment, and development and implementation of addiction science courses in the academic curricula of the various institutions. Again, to contribute to scholarly knowledge and enhance addiction science education in Nigeria and by extension, the entire African region. Now, a mixed method was used to integrate data from quantitative and qualitative and to understand existing gaps and potential challenges. And this was in the current landscape of addiction science in Nigeria. It utilized data obtained, of course, using a survey of stakeholders, consultations with educators, university administrators, healthcare professionals, policymakers, and community leaders purposefully selected from 8 universities across the 3 regions. Nigeria has 6 geopolitical regions, 6: Northeast, Northwest, North Central, Southeast, Southwest, and South-South. But this was from just 3 regions. And like I said, 8 out of 272, you can see the percentage of representation. So this is just an iceberg, just an idea of what it may look like, okay, and not representative of the real situation in Nigeria. I want to emphasize this. Okay. Now, analysis of the result obtained so far indicates significant lack of qualified manpower. Okay, and when we say this is in the sense of evidence-based professionals, those who have trained and retrained. I mean, if you are, for example, a psychologist trained in 1960 or 1970 or 1980, I have done nothing in the current sense of addiction science, we take you as non-qualified. Even though you have certification of board and all that, if you understand the sense of what I'm saying, or a psychiatrist, you have not undergone the current state training in the current, different updates and so on about the direction of addiction science, we take you as not being qualified. We don't mind that you have their names on the records. Okay, so 64%, and then inadequate infrastructure, 52% of the respondents said so. Now, the resource availability deficit, delay in approval by regulatory bodies, 85% of the respondents. Disruption in academic calendar, 89%. Paucity of teaching equipment, 31%. And need to introduce certified programs, 70%. Let me say this once more, because my university is one of the 2 universities in the country that have addiction science program. And so I can share my experience as the lead person that pioneered the program from inception, pursued it through all the approval levels from the departmental curriculum committee, faculty curriculum committee, the postgraduate school curriculum committee, and making lobby among senators and all that before the approval came. But hopefully I'll talk about that in a jiffy. So now, further analysis of data indicate awareness of UTC and UPC. Okay? While access to training is low, 25% of respondents have participated in any of the treatment models. And let me say that in Nigeria, probably over 5,000 or up to 10,000 people, in fact, maybe much, much higher, have had, I mean NGOs, private individuals, some people in the academia, a few number, have had some training programs either by United Nations Office on Drug and Crime or by Colombo Plan and so on and so forth. In fact, I was in a discussion with the national president of ISOP Nigeria, Dr. Martin, who unfortunately is again not here because of visa denial by this country's embassy in Nigeria. So we were discussing about the profile of his activities. He has an NGO, a non-governmental organization that is involved in substance use prevention and promotion of treatment and all that. And he's trained extensively in Colombo Plan programs and UNODC. So that his agency trains a lot of Nigerians on UPC and so on and so forth, UTC and so on. So I asked him, Martin, from the time we started training, about how many persons have gone through your training system? He said it's probably over 5,000. About 5,000 people who have been trained either in UPC, UTC, or other programs. And so you can imagine that many of these people also, some have non-governmental organizations of their own, some are in other capacities, and they may have trained also a multiplier of a good number of persons. Okay? So, this is just to note, yeah, it is penetrating, but we still need more data to talk about the impact. Okay, so if you look at the survey results and the challenges, so you can see the lack of qualified manpower, and please note that definition of this. Then inadequate infrastructure, delay in approvals. And I tell you this about delays, it's not a small thing. And maybe I should share my experience. When you want to introduce a new program in the university, I don't know your experience in your countries, it's not a joke. Because at all levels, you must explain why the program is important, who are going to consume the program, what is the possibility of its sustenance, and all that and all that. You must continue to explain this and defend this. And remember, you are dealing with fellow academics who also have information. So it's a huge issue to mount a new program, at least in my university and many universities in the country. I don't know about your own experience. I guess may not be far from that. Because universities do not want to mount programs that will not be subscribed to, okay? And so on and so forth. So like I said, in my department, one of the things that I did when I had this motivation to push for this program, indeed our own program is a postgraduate program, a master's degree program. My motivation was to ensure, because a lot of people, those who have had UPC training or UTC training, like I said earlier, some of them are working with government agencies, for example, the drug and what we call our organization for drug use trafficking prevention. Okay, so many of them they were interested in having PG certification. Okay, about to further their training and gain more competence. A good number of them made input in support because at the point I needed to get some form of information for the department, because that's where the program is anchored, to see who are likely to subscribe to this program. Okay, so immediately we got it through from the department, and then it was a little easier at the faculty level, because now members of my department were in support at the faculty level. It was a little easier. And then at the Senate level, at the project level, it was a big fight. The graduate school was very scrupulous, very, very scrupulous. You know, we are in this program already working who are the subscribers, all that. And after about 3-4 go and back, make corrections about 3 or 4 times, we're able to scale through the curriculum committee and then in the Senate. So it can be a slow process, okay? It could be quite slow. And if you are not strong or motivated to do that, to follow it up, especially when there is no funding. I tell you, I had no $1 or naira in this program. Sometimes I have to take my colleagues out for a lunch. If I find the argument very strong, I just come after, I say, James, why don't we go for a lunch? So we go to a private discussion. I say, look at this program. See the drug issues we have. Okay, look at our young people. Many people are getting into drug use. We need this program to bring capacity building. Those who are already working there, they need to do some of refresher programs to be able to do their work with new state of knowledge in the area. And afterwards, okay, now I understand what you mean. Next meeting, please invite me. So that's the point. It could have a lot of delay, especially if you are not very determined. It can just fizzle away. Okay, so there appears, even though there is now a huge curriculum review program, what they call the CMAX, okay, replacing the BMAX you have, but at the time, not many departments have had curriculum review, okay, from the time frame we set, but there is a lot of changes now going on through the National University Commission, okay, there's a lot of changes going on. And then some of the programs also had input from UTC, UPC. Yeah, I would say this is not verbatim. This influence, UPC or UTC influence and so on, for example, myself, I haven't had all these training programs. We still needed to look at our environment, okay? What really will make meaning to our people? What are our areas of need? What do we think will be important in this? And what do we think will not make meaning? What will those who are for this program, what will they need? And we'll give an example. I think I've shared it with a few of us here. A small organization in my country had a small funding to provide harm reduction program in this, and that was a syringe and needle program to substance users who were injecting. So they got all the approvals, and midway in the program, some community members attacked them. They attacked the organization. And what was their anger? They said, by giving needle and syringe to people who use drugs, you are promoting crime. Because they believe that people who use drugs commit crime. Okay? So they represent a group that, okay, if they don't, because many don't lose their jobs, so they can do anything in the street in order to access drugs. And so by giving them this needle and syringe, then you are promoting criminality, and you don't like our society. So you are an enemy of the society. Okay? Meanwhile, elsewhere, for example, United States, this will be a different thing. Okay? So we consider the need to look at our environment in terms of what and what will be in the curriculum. Okay? So like I said, 2 universities in Nigeria already have developed the program. My university, Nigerian University in the southeast, and Niger Delta University in the south-south. For that of Niger Delta University, their program is a postgraduate degree program, while ours is a master's degree program. A few other universities, like University of Benue State University and River State University, they are also upcoming. And part of what we have done to encourage this development, although this is slightly different from our study, this is my report as ICT General Rep in the country, part of what we have done is to encourage professional bodies to insert academic programs, the need for academic programs in addiction science during their conferences. And many times they invite us, we discuss about it, and people get interested, and gradually they're picking up interest in developing curriculum or curricula related to addiction. Okay? Now, there is need to train professionals in order to standardize practice of evidence-based services. The needs assessment outcome advocates for implementation of curricula that enrich academic offerings and empowers future professionals to contribute to the mitigation of substance abuse issues that align with global standards in addiction science. Thank you very much for your audience.
Thank you, Professor, for very clear. We are aware that this is ongoing survey, so we remember this is an ongoing. It is not representing data from the state of Nigeria because of the lack of responses, if I may say that. And I open the floor for questions, please.
Thank you, Prof, for the presentation. I have like 2-3 questions. I know that you said it's preliminary data. I wanted to know, because your category of participants is very diverse. So when you look at the regulator, and then you look at somebody from the university, I've forgotten the other categories. I was wondering whether you use the same data tool to collect the information. That is number one. I'm just thinking, I'd be interested in your data collection tool. And then, and the justification of using the same tool for the different categories of your participants. And then the second question is that the study used mixed methods. And then in terms of the presentation, because you use qualitative and quantitative methodology, I didn't, or you are yet to analyze the other methodology, qualitative, because I don't think it came out for me. And then to think about, like, how do you analyze using mixed methodologies in terms of your results? And then to also unpack the results of, because maybe if you shared with us the data collection tool, what informed it, the items in that, so that it becomes a bit clear in terms of your presentation of the results. So I think I'm gonna just stop there, and then just highlight on your mixed methodology of the qualitative and quantitative. Thank you.
Okay, the first thing I would like to say, first, which I emphasized, the pool of data that have been collected, a good number of it has not been analyzed, especially qualitative data. Okay, yeah, because there were interviews and so on. And I think I said that at the presentation that this is quite preliminary. We target to get more universities, because there's no way you can have, a population of, say, 272, and you're using N as sample, 8. So if that had been done, we would have seen a little more information. And I think that is like one answer to all the questions, as it were. Thank you.
For university, for regulators, was it the same?
No,
it wasn't.
No.
Maybe like in terms of presentation.
Let me give you an example.
Okay.
If, for example, you are a university administrator, okay? For example, a vice chancellor, you may not have the type of information the head of department of psychology will have with respect to the program. The vice chancellor will have a different type of global information. The head of department of psychology or psychiatry, or the provost of the college of medicine will have the type of information. The provost of college of medicine have the type of information the vice chancellor may have, but the head of department, say, of psychiatry may have more details. So there are different information gathering systems. Hopefully, if there is any little support, this study would have gone a little further. Okay, but you know, I do it the way we can afford that spare time and all that. So, in fact, I was discussing with Sam whether you know the data is enough. So, well, we can present what we have. So, I'm sorry, but that's the situation. Thank you.
Any other questions? Yes, please.
Thank you so much, Prof, for your presentation. I'm just interested and intrigued by the needle and syringe exchange program that you alluded to. And I was wondering if it's still happening. Was it discontinued? Because I'm from South Africa, and I know that the challenges we have around human rights violations, etc., is rife when it comes to needle and syringe exchange programs. So your program, is it still running, or has it been has it stopped? How is it just in one area or city in Nigeria? And do you have any advocacy efforts to destigmatize harm reduction services in Nigeria? Just general information. It's got nothing to do with your the presentation, but you alluded to it.
I'm sorry, I'm not sure I heard you very well. I'm sorry, can you repeat so I can get you more clearly?
Okay, is that better? Can you not?
Yeah.
Okay, so you spoke about harm reduction services.
Yes, harm reduction, yes.
Yeah, and needle and syringe exchange programs. And I said I'm from South Africa, and we've had a lot of issues around human rights violations for people
use the microphone more.
For people that go for needle and syringe exchange.
Yeah.
And I was interested to know whether your programs, how widespread are they in Nigeria? Have some been discontinued or affected by the fact that there's a lot of stigma associated to harm reduction services? And the last one is just, are there any advocacy efforts from whoever it may be to destigmatize harm reduction in Nigeria?
Okay, thank you very much. Yeah, there are. I mean, nothing is static. Many people, in fact, this came out in a conference. This report came out in a conference. And there's no doubt, many people, even that agency, that non-government agency, went back to the community later for some form of education, okay, to build a peace pathway and to explain herself, because the organization works in that community. Okay, so probably without that it would have been a little more difficult for them. Yeah, so there are quite a lot of efforts, okay, at trying to let more people know about this. But the context in which I presented that was on the need for culturally relevant content of training programs, okay, because sometimes people think that harm reduction or other practices that are promoted, I mean, that they are rocket science. So what happens or applies in country A must apply in country B. So I was making the point that it's not always the case, and that's why before you are taking anything, hook, line, and sinker, you do some form of local validation. Does this mean anything to our people? How will our people respond to this? And that's on one side. On the other side, there are a lot of advocacy efforts to promote, to enhance integration of people who are using substances. A whole lot. Okay? In the conference just concluded, Nigerian Institute of Social Psychologists conference, there was a big discussion, one on curriculum development in higher institutions of learning, by universities, and then two on discrimination, prevention of discrimination against persons with substance use disorder. But the question came up, maybe I share this. The question was, yes, that there is an agreement that integration, prevention of discrimination and all that will help in reintegrating people who are using substance in their treatment, in their recovery, and so on. But the question that was raised, what is the role of discrimination in substance use prevention? There was a lot of argument. Some people were, positing social psychology perspectives about modeling, okay, that societies use discrimination to inhibit behavioral patterns that they feel are not appropriate. Okay? So there were a lot of discussions. And then people said, okay, we need to find out, we need to do some research to see, is there any role to balance in terms of discrimination or stigmatization in decreasing substance use from a social psychology perspective?
Well,
Okay.
I have to intervene because of the time, and please keep questions relevant to the theme. Thank you very much. I'm sure that this is very stimulating. I'm afraid there is no room for question right now because of the time. May I introduce the third speaker, Dr. Rania Mamdouh. She is an associate professor of psychiatry at the Addiction Psychiatry Unit, Psychiatry Department at Cairo University, Egypt. She is a member of the Egyptian National Observatory for Drug Use Technical Committee. She's an ICU-DR member for the English-speaking countries in Africa. Also, she have an interest as the manager of the Recovery Club for Women and for Men, and the Serenity Girls Rehabilitation for Women in Egypt. And finally, she is the ISAM regional representative for North Africa and West Africa. Dr. Rania.
Thank you, Professor Tarek. Thank you, dear audience. Today I'm delighted to present the Egyptian experience in the substance use disorder university professionals educational needs assessment in the process of developing an addiction curriculum for universities in Egypt. I'm not going to begin with, like my colleagues, with the prevalence of substance use in the countries. No, I want to give you a brief about the worldwide status of addiction sciences curricula. There is an increasing variety of evidence-based treatments for addiction, including psychological, social, and pharmacological interventions that are available everywhere. However, these addiction treatments are only available in 30% of the countries. In the WHO report since 2017 till now, although we have a tremendous achievements in many psychosocial interventions and therapeutic interventions in the addiction sciences, yet only 30% of the countries, the patients in these countries receive good evidence-based treatment, and 70% of the globe countries do not receive it. This gap between scientific knowledge and daily addiction treatment partly results from the lack of adequate training in addiction medicine for healthcare professionals in many countries. In the last 2 decades, increased attention is being placed on competence-based education as a means of optimizing the initial and postgraduate education for health professionals. What does it mean? It means that some countries, it's not enough to have a curriculum for addiction sciences and not enough to make a training for addiction sciences. We also would need to be sure that this curriculum and this training will be core competent to make with a deliverable outcome of a substance use treatment professional. So many countries like the US, Canada, UK, and the Netherlands did make a tremendous effort for competence-based postgraduate addiction education to be well established. For example, a country like Canada, they agreed about 35 core competencies. Each curriculum should have a 35 core competencies in order to deliver a substance use addiction professional, treatment professional. A country like US, they agreed about 8 core competencies. The ISAM agreed about 35 core competencies. Until the SAMHSA, the substance use and mental health services for the US, between the 2014 and 2016, they agreed about 123 core competency in a curriculum in order to deliver a substance use treatment professional. However, this is not the case in the global scale. For the development of addiction medicine curricula or an addiction science curricula, it is important to know what specific addiction medicine competencies should be taught to different health professionals at different levels of education and specialization. Also, little is known about such differences in training needs across professional working in different countries. Later on, in addiction medicine training and auditing, self-assessment were increasingly to support the self-regulation, learning, and identified standards of excellences. They started to use the self-assessment for professionals and for the students. The surveys started to be used to see whether the curriculum is appropriate for the student, and he is appropriate for the university, and appropriate for the professionals who are delivering the curriculum. So this was one of the milestones who tried to identify the standards for excellence, competence gaps, and training needs. Until 2020, when the ICU-DDR made the ICU-DDR needs assessment and preparatory work for universities questionnaire. And it has been implemented in many universities cooperating with the ICU-DDR. Then the first country in Africa who did the questionnaire and made the assessment research was South Africa. And we are proud, my Egyptian team, to be the second country in the continent to try the ICDGR questionnaire for university professionals. The team was, let me allow to introduce you the team. These are the professionals who are working with me in the research in Cairo. This research was done with 3 universities, not only Cairo University, Bani Suef and Cairo and Fayoum University. We had a hypothesis that not all the disciplines working with the substance use patient do receive knowledge, skills, and training needs. All university professionals, including residents, assistant lecturers, rectors, suffering from deficiency of curricula in treatment of substance use disorder, availability of multidisciplinary specific curricula in treating substance use disorder depending on the demand of the team will be efficacious. This was our hypothesis. And the aim of the study, number 1, is to build a network. Without this network, neither the survey would be done, nor the future curricula would be done. So the first aim was to build a network of universities and other training institutes. We have in Egypt 29 provinces. So we thought to make a network from the 29 cities or provinces in Egypt, uniting 46 universities, preparing them and engaging them with us for the questionnaire and for the curriculum. Then assess current science curricula available in Egyptian universities. Then identify the need of new specialized addiction science curriculum, and to identify certifications for multidisciplinary professionals, and to assess the feasibility of implementing the UTC and UPC in Egyptian universities. The method, we went both ways. We were preparing the ICU-DDR questionnaire. It is in English, so it has to be translated into Arabic. It is 26 questions, has been translated and back-translated for standardization and reliability in Arabic. And the electronic version in Arabic was done. And the question 24 was general asking generally about the required knowledge, attitude, and skills for the candidates. We made it more detailed, so we were helping the candidates who apply for the questionnaire to choose from the choices. Then for the universities, we mailed 49 universities in Egypt do contain medical school, psychology schools, social sciences, nursing, and pharmacy schools. Medical schools, we did email psychiatry departments, toxicology, public health, and internal medicine. An official letter was done for the head of departments. There were a little challenges in the beginning that we waited for 3 months. Little reply were done by official letters. Then we started to make personal connections and WhatsApp using, email using, phone calls, until we had the significant, statistically would be significant number of replies. What about the results? Now, you will be noticing here that 32 medical schools out of 41 answered the questionnaire, with 20 schools of pharmacy out of 49, 10 schools of education out of 26 answered the questionnaire, 12 out of 23 psychology schools answered, 5 out of 10 social sciences schools answered, and 16 schools of nursing answered of 36. And it was significantly, we can rely on the information. And from the 41 medical school, 32 psychiatry department from the 41 psychiatry department replied, 20 toxicology department replied, and 19 public health department replied for the questionnaire. As regard the availability of addiction science curriculum, it happened that 85% of the universities in Egypt do have an existing addiction curriculum. And another 15% of universities do not have an addiction science curriculum. About those curriculums, 37% of those curriculums are courses, are different courses, for example, brief intervention course, harm reduction course, then later on CBT course, and that's like this. And 45% of those medical schools and universities do have a module, a course within the psychiatry or psychology or social science curriculum. 22% have a scientific degree, a master's degree, and a PhD degree where at least 6 months of addiction curriculum is present. 6.4% have an undergraduate diplomas, and 10% had a postgraduate 1-year diploma. As regards the availability of resources in those departments, 76% have qualified staff to deliver addiction curriculums. On the other hand, 53% do not have a multidisciplinary team to deliver the curriculum. For example, the psychology school only have psychologist staff to deliver psychology, but they do not have with them a psychiatrist or a public health or a toxicologist or a pharmacist to contain the more of the curriculum. 71% have good capacity to conduct a research, and 61% have the necessary practitioner for experience, and another 66% of the department have capacity to implement program. What about the gaps and challenges? In the red were the main gaps. The first gap where the staff professionals in universities complain of the limitation of time available for teaching. Next was that there were not enough practical training in the curriculum. Third thing is that some universal treatment plans are incompatible with the Egyptian culture. We should not bring an addiction treatment program from outside, wherever the country, and just deliver it to our students without sensitizing it to the Egyptian culture. What were the solutions from the perspective for the current programs? 30% of them think that creating a universal university's curriculum for Egypt, respecting the regional and country context, was a solution. And other people showed that updated training, including field practice in accredited centers, and cooperation with university medical school to develop curricula for teaching addiction science. This was the psychology departments at social sciences. They wanted a collaboration with the medical school, so the staff for psychiatry go to the psychology school and complement with their curriculum. This was the result of the psychology schools. As regard how universities are open to additional support, 90%, 91% of the staff in universities are saying yes, we need collaboration and we need additional support for curriculums. What are these kind of support? The main three were integrate some of the UTC and UPC material into existing course for undergraduate and postgraduate. They do not agree to take the UTC or UPC as per se, but they could integrate it and adapt it in the already present curriculums. And develop a standalone degree. They would love to develop a standalone degree only for addiction. In Egypt, in order to be an addictionologist, you need to have the master degree for psychiatry, then another master degree for addiction. They need 81% or 63% of the questionnaire of the respondent wanted that there be a standalone degree for addiction regardless of the degree in psychiatry. What was very nice for us as a result, what about the knowledge they need in the future curriculums? Screening, okay, is one of the subjects. Types of addictive substance, because now in Egypt there are a big change in the map of substance use, so many new types of substances are into the market. Health social consequences of the disease should be in the knowledge. Neurobiology of addiction. But what was surprising for us, that the respondent wanted to know about treatment on the patient in prison alternatives. This was not expected, but it went from the questionnaires. What about the skills they required? They required to know the group therapy skills, motivational interviewing skills, and skills for individual psychotherapy. What about the attitudes? They want the future curriculums to teach them or to train them about how to fight the stigma against the substance user, the ethics, female discrimination in intake and recovery, and the personal and group supervision. And this was one of the very respectable points that I did really respect all of the university staff in Egypt about it. That they do believe in peer supervision and personal supervision, and they do acknowledge the training in such areas. What were the potential candidates? 71% of the respondents saw that the existing professional already working in the field, they are the priority for the coming curriculum. For example, psychologists and the young physicians and young psychiatrists who are graduated, rapidly they are in the field. They are in the process of making a degree, yet they are working and they need information, they need training until they have their master degree or PhD degree. So these are the main candidates for the next curriculums. So summary, with this questionnaire, definitely the questionnaire gives us much more information of that, but for the time, your time, now we know the need in Egypt for future addiction sciences curricula. We know that we want the modules and curriculums for the young physicians and psychologists and social scientists. We know the infrastructure. We know the available treatment programs, but one piece of information that was not presented, that there is not enough recovery curriculums, no enough outpatient and brief interventions training. They needed that. Now the stakeholders inside the universities and outside in the ICU DDR are ready to collaborate. We know the objectives of the future curriculums. We know how to address what are the core competencies we need, we know the target population, we know the practical diplomas we can do, and we know the specific treatment and rehabilitation techniques required and needed by our young physicians and young psychologists. Thank you very much. Thank you so much.
Thank you, Rania. But since I'm sharing the session, I have a privilege to ask one question. Is the survey that the tool that you were using are unified between the 4 parts of the continent, or each one of you developed its own survey?
The same question.
I think this is partly answering part of your question, and Dr. Rania just presented in the first couple of slides the structure overall of the survey, which we are talking about a relatively equivalent data with different responses in the from different regions or countries that we have. Especially Dr. Zuma reminding us of that, of the underestimation of the responses in a big country like Nigeria. Questions?
Let me thank you for your very, very comprehensive presentation. I have 2 questions. The first, in the first slide, you said that in Canada, in Europe, in the UK, they have already accomplished programs for educational for addiction. What do we still missing compared with these programs? Number 2, in your presentation, you asked everybody about their curriculum about addiction. Did you differentiate between undergraduate needs and postgraduate needs, and those working with prevention and those working with interventional treatment? Do we need specific programs for each team of them or not? Thank you.
Thank you, Dr. Nahla. If I might add, Finland and Norway have also established a curriculum for addiction.
Thank you, dear Professor Nahla. First of all, I would like to thank you, and I really am acknowledging your collaborative spirit, and I'm very happy that you're with us today. I really thank you so much. The core competencies, it's a way for assessing all curriculum since maybe 2009. Each country identify the core competencies for the curriculums required and how would be a substance use addiction professional, the level of knowledge, his level of skills, and his level of attitudes. In Egypt, you know, you are a university, an eminent professor staff. While we are doing the blueprinting of any curriculum, now there are deliverable outcomes. For the last 10 years, we're now acquainted to make the deliverable, and the core competencies we are obliged now to make this in our curriculums. Yet in the addiction curriculums in the other theoretical schools, psychology, social science, if you see that 13 schools of education, kulliyat tarbiyah, they answered. A school of pharmacy answered. They didn't have addiction curriculum, and they require it with the equivalent core competencies. They cannot make a core competencies for those curriculums unless they have a professor like you or someone from the addiction science with them. Your second question is, yeah, it is present in the question because of the time I didn't present that, but in the qualitative assessment, this or majorly quantitative one. In the qualitative, we noticed that the medical schools are targeting, they need small modules, harm reduction, brief interventions, and the contingency management. While the theoretical schools. It was qualitatively. They needed the neurobiological basis, and they need training in the practical field in our schools. So they wanted that the social scientists attend around with you and with the physicians to get to know more about the patients and to be inside the experience. So it was qualitatively. So the schools of theoretical backgrounds, psychology and social and nursing even, they wanted certain qualities other than the physicians. But in order of the time, I did not present it here.
Question, please.
Out of your data, was there anything that aligned with ISAM and SAMHSA's competencies? Like out of the data that you have about the different professionals and universities, I'm just wondering, the things that they highlighted in terms of a need, did it align with ISAM and SAMHSA's competencies? Okay.
I can forward it to you, Dr. Morocco. I have it. I have the 35 core competencies for Canada and the 9 for the ISAM and the 123 of the SAMHSA. And the 123 for the SAMHSA are covering almost everything. And we can forward it to all of us in order that we, in our universities, we get use of it.
Questionnaire that.
Can you take the mic? please?
Okay,
Because-
so for the questionnaire, does it capture some of these competencies in terms of your construction of the questionnaire?
The original questionnaire does not ask about it.
Oh.
That's why we said that the Egyptian team added to question 24 that we wanted that the respondent do think and do elaborate more. So
Okay.
it was an Egyptian addition on the questionnaire.
Okay, no, thank you.
So what we understand, there were core questions, and then each investigator country can or could have add according to the needs of the culture there. So there is a standard questionnaire, and then add on. It depends on the culture. We have yes.
Thank you all. My question goes to probably the three of you. About the tool that was used, how do you think it would work in smaller institutions, not universities, like schools of nursing, school of psychiatric clinic officers, because there are quite many in my country, and such a survey would be good in those small institutions. How do you think it would work? And then maybe the other question is the tool easily available for us who might want to try it? Is it readily available, or do we have to go through, certain permissions and all? How well can the tool be used in smaller institutions, which are not universities, but teaching, mental health related courses? And then the second question is the tool available easily for us to use?
Define small. What do you mean by small?
Not universities, like institutions of learning, like schools of nursing that are probably attached to.
Right. Thank you. Sure.
Yes, if I want to add to what she was saying, my own question is, apart from high institutions, don't we go to primary and secondary? Does this research cover such tertiary institutions, apart from just university? Because the problem we're having with drugs and substance use is just still at the top. We still focus on the top. What happened to the grassroots where the problem actually starts from?
Okay.
We're not looking, we're not addressing that. We
By
keep
definition.
talking of the top universities and all.
By definitions, this is a university consortiums. So we are addressing at that level, on our level here, the universities. That is why we went to the universities, not, and I agree with you fully, that is need of more elaborate survey. But since we are the ICU-DDR, which is International Consortium of Universities, so we address universities, basically.
And just to add to that, by training university professionals, we equip them to deal with the grassroots issues, because that's the gap. So we can't, I mean, we do preventative at the grassroots, but the survey was for professionals and university students that can be equipped to address those issues.
It is limited, yes, in a sense,
Yes.
but that is our domain for that. You're most welcome. You're most welcome. Thank you very much for the question, but it is very well taken. Thank you.
Yes, to answer the first question, this tool is available to whoever wants to use it. So, you just need to contact one of us and we will make the tool available to you. If I understand your second question correctly, can you use this tool in smaller schools, or school of nursing or school of teaching? Is that the question? We did some smaller colleges and institutes. However, I think you will have to adapt it a bit, because this is more for larger universities and for big faculties and departments that have a professionalized degree, diploma program, or planning to implement. So for your nursing department, maybe the requirements and the needs may be a bit different from the university. So it's open to be adapted as well. Does that answer your question?
Okay, for the core competencies, you can find it at the website of ISAM, www.isamweb.org. It is listed there. And for SAMHSA, it is already published in one of its tips that I cannot remember the 21. Right, thank you. So it is also, you can download it freely, and I'm not quite sure how many languages that it is written for, but definitely English is one of them. Finally, if I might conclude, 2 points. 3 of the people sitting here and 2 just left are board member of the ICU-DDR. And the reason of that survey is recently, or this year, the ICU-DDR is acquiring a new role in disseminating and overseeing the training of the UTCs. And also there are new buds underneath the umbrella of ICU-DDR, where accreditation and credentialing the degrees are among our domain right now. So this survey, and perhaps others, will help us to address that particular need. And your contribution is highly appreciated and respected in that matter. And the final comment is for our friend from Nigeria. We discussed the matter of denying visa. And I assure you, as the organizer of Abu Dhabi 2022, which is myself, it is a horrendous work that organizers, and I praise our Greek colleagues on what they were doing to inform the foreign ministry of the country of the conference, to disseminate the facilitation at their embassies all over the world. And we double-checked, we triple-checked, and it was disseminated. But again, of my experience, I'm not going to say for how many years in preparing international conferences, this is a nightmare. It takes most of our effort. The least is the places we are in, the catering and the the whatever that we are providing, but the most is to ensure facilitating our colleagues to attend and come. And thanks for the INL and its sister organizations in supporting and facilitating all of us to be here. And again, all due respect, but we are really not very happy of the incidences, even for one person. That is not our aim indeed. And thank you for coming in the hot weather to hear and to attend and to listen and to participate with us. Thank you, and thank for the honorable speakers. Thank you very much.